Welcome back to the Better Health Now podcast. Today we have a familiar face back on the podcast. Today we're talking with Dr. Eric Goodrich about ACL reconstruction. To get us started, for those that maybe aren't familiar, what exactly is the ACL?
Okay. Well, thanks for having me again. I appreciate it. So we're talking about anterior cruciate ligament. So there's several ligaments in the knee. So you have the anterior cruciate ligament, and you have the otherwise known as the ACL. You have your PCL, and you have your collateral ligaments. Among of those are mostly the most important ones. And the main how the ACL works, it actually resists rotatory motion and also helps the tibia stay in place.
Mm.
So when you are jumping or you're landing, the ACL helps to prevent the tibia from going forward and then also prevents it from rotating. So you need a functioning ACL to jump and do any type of pivoting. Even if you're a contractor jumping or going up and down ladders, you need that kind of ACL, that constraint to have a stable knee.
Yeah, and I mean, I feel like a lot of people are familiar with ACL tears, and in general, it's pretty common sports injury that
Yes.
like you see from basketball players to football players to really any athlete. How do you kind of diagnose it? Is it a physical exam or is it imaging and MRIs?
It's a combination of everything. So it all starts with history and physical. So I know if someone comes in and they have a swollen knee and they felt a pop and it got very swollen within 15 and 20 minutes, my first thinking is ACL until proven otherwise. So they come in the clinic, they have a very swollen knee. They say, "Hey doc, I was a non-contact injury." You'll see on football games or baseball games, a running back or quarterback will be running out of the pocket, and then they land and it's a non-contact hyperextension knee injury. And then as soon as I see that, I'm like, that's it. So that's history is important. There's also physical exam things that I do in the office. So I do something called the Lockman maneuver where I take the knee and I move it back and forth, and I can tell pretty immediately if I know the ACL is out. And then I also assess the other ligaments as well because it is also accompanied by other ligamentous and meniscus injuries. Most commonly, it's the lateral meniscus that's torn in acute ACL. So I would expect to be a tear there. And then sometimes the medial meniscus is torn or both. And then sometimes you can have some cartilage injury from that. So it's a history and physical exam. And if you come to see me, we'll get an MRI as soon as you come to the appointment. And we actually get them pretty quick. It's about within a week. Now I look at the MRI myself. I also look at the radiologist report as well, and I can see clearly that the ACL was gone. You'll see a bony bruising pattern of the tibia and the femur, that which is characteristic, and it'll help you diagnose and confirm that you have an ACL tear, if you have a meniscus tear, and if you have a collateral ligament tear, such as the MCL or the LCL. So that's kind of how I come up with my
Yeah,
diagnosis.
and I feel like I mean, like, the stuff that I've seen whenever you hear about an athlete tearing an ACL, it's typically do you see it most common that it's multiple ligaments within the knee, it's not just the ACL, or do you see it where, like, it is if it's just the ACL, we see that more often than not, or vice versa?
It's a combination. Sometimes it's purely just ACL.
Mm,
Sometimes it's meniscus. Sometimes it's both, and sometimes you don't know until you get in there.
mm,
So sometimes the MRI won't show everything, and will go in the knee. I'll do my diagnostic knee arthroscopy, and I'll find something that surprises me. So anytime that they come in for that, I'm prepared to do a meniscus repair. I'm prepared to do a ligamentous repair. So it kind of depends. So I'd say I don't know what the percentage is, but sometimes they have them by themselves, sometimes they're accompanied with other injuries, but, I think just going in there and being prepared for everything is the key.
yeah, and so talk a little bit about what the reconstruction process looks like for the patients.
Okay.
They come in, you do all the checks. Hey, it is what we thought it was. You ACL injury, or oh, there's other ligaments. What does that sort of that reconstruction process look like from the patient's perspective? Kind of leading us into maybe some of the other cases and of the other ways you do the surgery.
Okay. So first we talk about what ACL reconstruction means. We talk about rehab, we talk about risk, we talk about benefits, we talk about complications, and is ACL surgery right for you? So usually if you're young, usually we recommend ACL reconstruction surgery. If you're an older patient that's not, a little lower demand, in their mid 50s to 60s, may consider just bracing and non-operative treatment. But so first we had that discussion. Hey, you know, it all depends upon what kind of job you want to get back to. So if you work a desk job, we talk about recovery could be you could be working as soon as 2 to 4 weeks.
Mm.
If you are a high demand athlete, if you're a college football player or professional, you're looking at a minimum of 9 months. So it depends upon what your job looks like. So we have a conversation beforehand and expectations. So they'll ask me, I'm like, okay, what do you do for work, or what do you like to do? And then they'll tell me, I'm like, okay, well then expect like 6 to 9 months, or if you really get back to something that's high impact activity, I say about 6 to 9 months plus.
Wow.
So it's an outpatient surgery. It usually takes me about 60 to 90 minutes to perform. If there's any additional meniscus repairs, it takes a little more time. And then recovery, usually go home the same day. Um, Usually from 0 to 2 weeks, it's a lot of rest. You'll be in a brace for about 4 to 6 weeks or so. And then it's a lot of physical therapy. So you'll be best friends with your physical therapist for a long time. So pick someone you like. So after that, you from 6 weeks to about 12 weeks, you still do a lot of strengthening. Around 3 to 4 months, you start a light jog, start a little bit of running. And then from around 6 to 9 months, if you're in a sport, you start doing sport specific activities. So you start doing cutting and testing everything out because it takes around 3 to 4 months for that ACL to start healing in the bone. So you don't want to do anything that's going to risk re-injuring it 4 months or less. So that's
Mhm.
why the recovery is so long because we don't want to start at ground zero.
Mhm.
So, and that's how usually I tell patients as what to expect after surgery and then a rehabbing.
Yeah, and so kind of transitioning from there, you mentioned some of the cases and talk a little bit some of the cases that you perform something called the lateral extracular tendos. Oh goodness
Lateral
gracious.
extra-articular tenodesis. It's
That
it's a
that
mouthful.
that is exactly yes. Talk a little bit about that,
Yeah.
because I mean, it's I obviously have no idea what that is really about.
Yeah. So it's a newer thing, a newer technique over the past 3 to 4 years. We're trying to reduce the risk of re-rupture, especially in young athletes or in revision. So it is something that I do for patients that are young. They're a high risk for what kind of job they do or kind of sport they do. If it's revision, if they have a really unstable knee, it's something that I offer. So I make a little small incision about 4 centimeters over the outside part of the knee. I take their IT band and then I basically wrap it around their lateral collateral ligament, and I use an anchor and I put into the bone, and that really tightens up the lateral part of the knee, and that prevents or helps with rotatory motion. It helps pretty much prevent that from happening. So it's a backup, and the studies show that this is something that it really helps with graft re-rupture because graft re-rupture is a big deal, and I
Mhm.
mean it happens, but this helps reduce the risk of it. So that's something that I do perform, and I do on the proper patients.
Yeah, and so talk a little bit about, that IT band reconstruction that you did on the 10-year-old. That's a I mean, when I saw that, it's crazy. I've never heard of someone that young to have an ACL injury. So talk a little bit about that, particular, operation.
Yeah. So usually, back a long time ago, we would just treat these patients non-operatively and then wait for their because every adolescent or young boy or girl they have growth plates. So and a male, growth plates don't really mature until they're about 16 years old. So that creates a problem. So we have to come up with a solution for that problem. And then there's a new technique where I take the IT band and I use that as their ACL. So that way I don't have to drill any holes in the bones. I bring the IT band into the knee, which is a structure on the outside part of the knee. And then I sew it into the bone in the tibia bone. And there's a very minimal risk of growth plate problems. With the other techniques, there's a higher risk for that, and those patients do very well. I just saw him at the 3 month mark. He's doing great, and he's already starting to do a slight jog, almost and then starting to do some pivoting work. And I see him in 6 months, and he's happy so far. And it's a new procedure done in the area. I don't think it's done in the area yet. So it's something that I could do and perform.
Yeah, and so do all, orthopedic surgeons perform reconstruction for pediatrics or for pediatric ACL, or is this something like you said, it's something it's fairly new, the process, but do you see it maybe in other in Birmingham or in Huntsville that pediatric ACL stuff is common amongst all,
Yeah,
orthopedic surgeons?
so, Birmingham and Huntsville, they definitely can they have sports surgeons that can perform that surgery. Um, but I've done a fair amount of those in my fellowship training in Columbus, Georgia at the Houston Clinic, and it's another tool that I have in the toolbox to help people in a small town. That way they don't have to travel to Birmingham and Huntsville. That's the whole key is I like to be able to provide, healthcare that, that's convenient for people and it's still state of the art, highly technically sound.
Mhm.
So I think that brings a lot to the table.
Yeah, and so, I mean, from the parent's perspective, what would you say to them who are scared about hearing their child needs to have an ACL surgery?
It is. It is it's a, you always have to have it's always a long discussion. I take the time with the patients to do that. So, it's always a shock, because you talk about, "Hey, if we don't do surgery, here are the risks or here are things that can happen." So if you don't do the ACL surgery, they can have recurrent instability.
Mm,
They can create meniscus tears. And if they keep loading their tibia on their femur, they could potentially increase the risk of osteoarthritis in the future. So I talk about all those things, and usually they're agreeable to that. But it's always a patient physician directed conversation where you try to have with them.
yeah, and so are ACL injuries themselves preventable, or what role does strength training play into kind of helping prevent ACL tears?
They are preventable. So the biggest thing that the movements you want to avoid that actually a lot of soccer coaches and teams kind of preach is you want to basically prevent the knee from going inward, and you want to have good core strength, you want to have good hip strength and good hamstring strength. So the biggest things I tell patients is that when you're jumping and you're landing, you want to make sure your knees are in front of your toes, you're not going in or out. You want to make sure that your knees are nice and your knees and your hips are flexed. You want to make sure that you have that good muscle strength training, and it can be prevented. There are some studies that show that ACL brace wear in skiers helps,
Mm.
and also offensive linemen, but it's not a routine recommendation to make.
Yeah, and so, I mean, obviously, sometimes the high impact athletes, ACL tears, their sports, baseball players, football players, whatever it might be, and that journey for them can be substantially longer to get back to that
Yeah.
level of competition that they're used to. Have you seen, since being here at Coleman, that journey for patients to kind of get back to that, or even as in your past, seen patients get back to that high impact and being able to perform at that same?
Yeah, absolutely. The expectation is get back to return to play at full capacity. It's usually I usually like to try to err on the more conservative side of things. So it's a minimum of 9 months for me. And there's different things we can measure to help that. So I measure the strength of the muscles. Physical therapy helps me measure it, and then we kind of make a team decision based upon that. But most people, even IT band auto reconstructions, do have a full return to play and should have a normal life afterwards.
Yeah, and so as we kind of wrap up the conversation talking about ACL reconstruction, is there anything else that you would like to leave the audience with about either the process, the surgery itself, the post surgery, the pre surgery, anything that you would want to leave them with as we wrap up?
Yeah, so there are three different types of grafts that you can do as well. So you can do a quadriceps tendon graft. You can do a bone patellar bone. You can do hamstrings, or in that pediatric patient, you can do IT band auto. I do all those. There are different kind of graft selections that are appropriate for different patients. I think that the graft selection is made between you and the patient. So the graft that I tend to use the most is the quadriceps graft. It's a minimally invasive incision. Make an incision over the knee. It's maybe about 3 to 4 centimeters in length. Just try to keep as minimalistic as I can. I would just not be, I would talk to your physician, talk to your surgeon, and it's a patient care decision of whether you need a ACL reconstruction or not. I think that most of the results are predictable, and we're getting better and better as orthopedic surgeons in performing the surgery. And I think that the patient results and getting back to activity is pretty good.
Yeah, I mean, I think it's incredible, to see kind of as we've talked through the different ways you can do the surgery, how there's always new ways to make the recovery better for the patients. And at the end of the day, you're working with the patients one on one to figure out what's best fit for them based
Yes.
on their current lifestyle, their future lifestyles, and all that in between. And so it's incredible. I enjoyed having you back on the
Well,
podcast.
thanks.
I
I
enjoyed
appreciate it.
kind of talking through this. We'll probably have you back on in the future talking about a different kind of surgery at some point. But we'll be sure to have everything in the episode notes for people to find out any information, anything that we've talked about. But thank
Okay.
you so much for being here.
All right. Thank you. I appreciate it.